from the academic perspective side of the house, he did his undergrad at Cornell, did his master's at a place called Harvard, and it's not Harvard, Saskatchewan, it's the one down in Massachusetts. He worked or studied under a good friend of ours, a good friend of CATAP, Mario Scalora, who's with the University of Nebraska, and I think still consults with the Capitol Police. Is he still with them? I believe so. Okay. So Eric is involved in that interface between PTSD and traumatic brain injury and also aggression, and his present work is in that area, and he'll fill in a little bit more about his background, and I'll turn it over to Dr. Elbogen.
Thank you.
Turns out we may be related. This is, yeah, okay, scary.
I don't know whether Sean is still here, but I wanted to thank him for 3 reasons. One was for his service. 2, for the amount of courage that I can't fathom what it took for him to stand here. And 3, for the fact that after today, I'll never have a tougher act to follow. I'm going to be talking today about the role of PTSD among military veterans. I started in the field of violence risk assessment 21 years ago. I worked on a crisis team, worked along with law enforcement, where we'd go out into the community and assess people for hospitalization. Our team's motto was, "We're not afraid of commitment." Let that bad and what became apparent to me is that we should have been, because we actually didn't have a very good, clear idea of how to assess for violence. And so I went to the University of Nebraska and studied, met with Stephen Hart, Kevin Douglas, a lot of people here today, did research in the civil psychiatric side, and was in North Carolina doing my postdoc when there were a series of murders at Fort Bragg. There were 7 murder-suicides among active duty members. This is in 2002, in 1 month. And we were just starting to ramp up for the wars, and now the longest war the United States has ever fought in Iraq and Afghanistan. And I began to think, this great work that's been done with civilians to assess risk of violence, can we apply that to veterans? And that's the work I'll be presenting today, to try to give you a thumbnail sketch of what are some of the lessons that we've learned from our research. I could not have done this without my colleagues, and for those of you who follow basketball, there is a rivalry that you may be aware of between Duke and the University of North Carolina. It's one of the fiercest. But in this case, we get along pretty darn well. And also collaborators at the VA, Veterans Affairs. I'm going to put the question to you now before I start lecturing. I want you to think about this question. Let's say that you had a random sample of 1,000 veterans, Canadian Force members. What percentage of them, if you ask them, have you been aggressive or physically violent to another person in the past year? What percentage of them do you think answer yes to that? What I want you to do is to write down your answer. Okay? Raise of hands, who wrote A? B? C? D? E? Interesting, okay. So there's quite a lot of variability. Not a perfect bell curve, but kind of skewed to the right. Turns out that the vast majority of veterans are not violent or have aggressive problems or behaviors in that 1 year. Most research is showing that the prevalence is about 33%, and a lot of those are not severely violent acts, but other less minor forms of aggression. So the take-home message for that is most of our military personnel are actually not struggling with problems with violence. And I think that that's a really important thing to take away from today, because unfortunately we hear about the stories, I believe Steve talked about one of them, about veterans who do commit violent acts, and they get a lot of publicity in the United States and Canada. And that has a real impact on stigma, hiring veterans. There's a perception due to media that, oh, there's a knee-jerk reaction that it has to be that they have post-traumatic stress disorder and they're going to act explosively. And that's just not the case. To give you an idea, there are over 1 million active duty military in the United States and 22 million veterans. That number is going down. Women are making the fastest growing percentage of the military. As of now, they're between 16 to 17%. It's the same in Canada. Women make up, as of 2011, 15% of the Canadian Armed Forces. There are 65,000 regular force and 25,000 reservists. Between the years 2001 and 2014, over 40,000 Canadian Forces members served in Afghanistan. There is currently controversy and some news about whether or not Canada is going to be involved with the current crisis in Iraq, and there are 26 soldiers they are providing expertise and advice. So we heard this morning about what happens to one that experiences constant trauma and violence. What do you think, though, if you were to think about, who here has, raise your hand if you've encountered a Canadian Forces or military veteran, raise your hand. Okay, so thinking about that person, what do you think was the strongest predictor of violence for that person? So write down your answer. Who said A? Raise your hand. Interesting. Who said B? Raise your hand. C? Raise your hand. D? Raise your hand. E? Usually very few people, but you'll see it's a good answer. F? Okay. I know this is in bad form. There's actually no right answer. But there are some that are actually not related consistently. And male gender and traumatic brain injury have not consistently related to violence and aggression in veterans. So that's probably another important thing to realize. Younger age certainly has been. Criminal arrest before military service turns out to be one of the strongest predictors. We're going to talk about that in a minute. Financial instability, also a very strong predictor, and PTSD. We're going to talk about the complexities of that in a few minutes. When we're asked to do a threat assessment, risk assessment, left to our own devices, we do slightly better than chance. At least in the United States, with the wars that were coming to an end, but now possibly returning to war, we've had a lot of veterans come into the Durham VA Medical Center, Veterans Affairs, who are struggling with aggression and are not knowing what to do with it. They complain of anger problems, of violence. what can we do? And so what I'm going to show you now is these are the risk factors that have consistently been shown in scientific research to relate to violence in military and veterans populations. We did a review of, at the time, over 72 studies. Now there's over 90. And if there's a check mark there, those were in 4 or more studies to be related to violence. And younger age was there. Past violent behavior, having been exposed to combat, and we're going to talk a little bit about that in a moment, and maltreatment or abuse as a child. Meeting criteria for PTSD as well as PTSD symptoms, substance abuse, depression, and financial status. So if there are factors, if you are seeing that veteran again, these would be at least some of the things to be considering in terms of, is this veteran at risk? And what you might notice is, isn't this the same as, some of these are the same as the general population? And that's a really important observation, because veterans are also human beings and they have the same risk factors as civilians. So one of the key messages is that PTSD is going to be relevant and combat is going to be relevant, but so are those non-PTSD civilian risk factors too. They don't just suddenly go by the wayside. And in fact, in many cases, they're stronger predictors than PTSD. Is this relevant to Canadian forces? I looked, and I didn't find any articles that I'm aware of. If someone is aware of it, please tell me afterwards, that looked at Canadian military and aggression and violence. I did find some on suicide and mental health problems. And this one showed that about a quarter of the Canadian forces were at least self-perceiving a need for care. But of those that did, the vast majority of them were not even going to get help. So they knew they needed it, they knew they needed help, but they weren't getting it. Sound familiar from this? They made a distinction between just being deployed versus actually experiencing combat. And the mental health problems were related to not just being deployed, but actually witnessing atrocities, being involved in violent combat. And so while combat exposure is related to violence in the veterans and to mental health problems, you really want to begin to look at, well, what kind of combat experience or deployment did the veteran have? Because some of those experiences are unrelated. So an example, and this was military training itself has never been shown to be related to violence. The military training itself, it may lead to fears, and it's certainly relevant to a risk assessment, but in terms of the science, that alone hasn't been, but instead, witnessing combat, that's a stronger predictor. So we were fortunate that hypothetical, you got to have 1,000 people randomly selected. We actually did that study. We conducted what's called the Post-Deployment Adjustment Study. It was funded by the National Institute of Mental Health in the United States, where we got access to a random sample of everyone who served since 9/11. And what we found, we were able to get a 56% response rate. So of the 3,000 people, a number of them didn't have correct addresses. And of those that actually received the survey, 56% of them filled it out. And so we had a pretty representative. So the data I'm presenting to you and the information for you to translate into your, whether it be law enforcement, clinical practice, this is based on the most representative sample that's out there. We were able to get veterans from all 50 United States and 4 territories, and our responders had the exact military age, ethnicity, and geographic region breakdown as the actual military. For those of you in academia and Actually, for those of you who are not, I could tell you that to be able to get a representative sample like this was not easy to do. So this data is probably pretty reliable, but was hard fought. We measured violence. These are our definitions of severe violence using these scales. So you could see severe violence involved threat of lethal harm or use of lethal weapons, and other physical aggression would be less severe, certainly to not call it violence. That's more of an academic thing, but we made a distinction between the more severe violence and not. What I can tell you is that the average age of Iraq, Afghanistan veterans in the United States was 33 years, and 100% had a high school equivalency. I was looking, and that's pretty much the same for Canadian forces. I think it's important for you to realize that higher education is obviously a protective factor for violence. And if you find out that someone is a veteran, they actually are better, they are better educated than civilian population. So it's a protective factor that a lot of people might not realize in our veterans. 70% were Caucasian, and a lot were actually unemployed after coming back. And that's higher than our unemployment rate was at the time. 1 in 10 reported having been arrested before they were ever in the military. That is a really important statistic, because what we found is that that was very predictive of, after the military, them getting arrested again. A number of them had more than one deployment, some as many as 6, 7, or 8 deployments. And a number of them spent more than a year in Iraq and or Afghanistan. 1 in 5 met criteria for PTSD. So the vast majority of veterans don't meet criteria for PTSD. Now, does that mean that they can't get it in the future? No. But if you were to take a snapshot right now, you would actually find that most of them don't meet criteria. Certainly a lot more than the general population. 20% is far more than the civilian population. 15% traumatic brain injury. But more important than either post-traumatic stress disorder or traumatic brain injury was major depressive disorder, and the #1 mental health problem, alcohol abuse. You don't hear about those second two as much, but it turns out that alcohol abuse, not only in the male veterans, but also in the female veterans, was 3 times higher than civilian women. So the rate is very, very high among veterans. Could it be to be coping with PTSD? We're going to talk about that. It certainly can be. So the first take home is for you to take this science that we've done and to improve when you encounter a veteran, to improve your understanding of whether or not they might be at risk of violence. The first thing you want to know is, what are some of those risk factors? What are some of the risk factors? What's the prevalence? How often does this happen? What we found in that survey was 32% did endorse some physically aggressive act in a year period of time. 11% of those were severe. So just in terms of understanding what kind of violence you're going to be encountering, most of it with the veterans is less severe aggression. There was no difference between male and female veterans. That is very different than in the general population, where there's a well-known gender gap in rates of violence. So women veterans were just as likely as male veterans to answer yes to those questions. Younger age, financial instability, combat involvement, alcohol misuse, PTSD, arrest history before military service, violence before military service, witnessing violence growing up. Those were all statistically related to violence in veterans. Again, many of those are the same as for civilians. PTSD in combat, obviously different, but how strong were these? And how did they interact with one another? Because the whole idea is you have these veterans, you kind of see what those risk factors are. It's about 1/3 of them have other aggression, 1 out of 10 have severe violence, and there are these factors. But how does PTSD factor into it? So the second thing you want to know if you're encountering a veteran is does this person have PTSD? How does that relate to whether he or she is at risk in this situation? So what we did is we actually also were able to do a follow-up survey 1 year later. So if at time period 1 you have PTSD, in the next year, 20% of those people who had PTSD were severely violent. If they didn't have PTSD at the first survey, 6% were violent. So on the surface, that seems like, okay, the PTSD seems like a pretty important risk factor. That's statistically significant. You don't really need to be a statistician to figure that one out. And alcohol misuse, 17% were violent, severely violent next year, 6% not, again, statistically significant. But what about that overlap? We heard this morning about a story where PTSD and alcohol was involved. What happens there? PTSD without alcohol abuse, 10% of them were violent the next year versus 8.6. That's not statistically significant. Alcohol misuse without PTSD, 10% and 8. That's not statistically significant. When you had both, it over tripled the rate. That's significant. So there's actually a theory that says, it's a theory out of some, it's called the I cubed theory, and it's a theory about violence. And what it's saying is that violence is more likely to happen when something impelling someone to be violent is strong and when inhibitions are weak. So if you think about it, thinking about PTSD, if you have anger, but you're inhibited from acting on it, then you're going to have lower risk. If you just have alcohol abuse and you're disinhibited, but there's no anger, well, then you're a happy drunk. If you have anger and no inhibitions because of the alcohol abuse, that increases the risk. So that's our current theory about why the combination of those two is so deadly. And so I think it's really important that the next question, if you have a veteran in front of you, is not just about their PTSD, but are they drinking alcohol? Are they drinking alcohol to possibly cope with, to self-medicate, to deal with the PTSD? Goes a little bit deeper. You know, there's this DSM, the Diagnostic Statistical Manual, has psychiatric diagnoses. And what we found is that the term PTSD, the diagnosis PTSD, that itself wasn't relating to violence. It was specific symptoms within PTSD. You heard about some of them this morning too. The being on guard, the paranoia, that's called hypervigilance, the sleep problems. What we found is that among veterans, those symptoms and not the PTSD diagnosis is what related to aggression. So you have a veteran in front of you, you find out, do they have PTSD? Are they drinking alcohol? and find out what symptoms they're having. Are they angry? Are they not sleeping? Are they paranoid? Those are elevating their risk. Not just having the diagnosis, but what are the symptoms that you're seeing? The other PTSD symptoms were less consistent. This is criminal justice involvement for both post-traumatic stress disorder and traumatic brain injury. And this could be one reason why traumatic brain injury wasn't consistently coming up, is because you really need to divide them up into people veterans who are having PTSD without anger, and they're not at increased risk of becoming arrested, versus those that do have high anger and irritability. And this is a question, in the last week, have you been angry or irritable? And that significantly elevated risk. PTSD is different for different people. And so you want to be able to see what is it about that diagnosis that might be related to violence. Just having the diagnosis alone isn't enough. You want to look more deeply. Here's traumatic brain injury, and the brain injuries that led to more anger and irritability were associated with increased arrests. So even though traumatic brain injury wasn't on that list, certainly it's something to consider too, because of the potential for that to lead to disinhibition and anger. So you know what the risk factors are for violence in veterans. That's important. You want to explore what the role is, the complex role of PTSD. And now it's very important to see, well, what kind of violence are you actually even assessing for? What kind? Because it turns out that for veterans, different kinds of violent acts relate to, and problems with violence relate to different factors. So as a clinician, I might start off by asking, okay, well, are you having problems controlling your violence? And if the veteran says no, I'm relieved. But if he says yes or she says yes, then what I'm going to explore is, does this person have a history of exposure to violence? Did they fire weapons in the military? I start to delve into where's the source of these problems controlling violence. They don't have anger, they don't have problems controlling violence, go down to, okay, well, do you have aggressive impulses to smash things? Even if you don't have problems controlling violence, if they say yes to that, then that we found is associated with mental health problems. If they say no, then I ask, well, do you have problems managing your anger? And at that level, that we found is really related to relationship problems. So you want to look at both the type and the severity of violence that you're looking at in front of you. This is fairly small. I'll do my best to explain. We wanted to look at what are the predictors of stranger aggression versus family aggression in the veterans. And what we found is, what that circle says is that men were 3.4 times more likely to engage in stranger aggression than women. I know that for some that might be scientific empirical data showing the blatantly obvious, but that's what we found with the veterans. So there was a distinction when you looked at type of victim. PTSD flashbacks, in this case, predicted stranger aggression. And this is the first documented link between post-traumatic stress flashbacks and aggression. So the stranger aggression, what was relevant. What we found, though, is that women were significantly more likely to report and engage in family violence, women veterans, and that it was PTSD anger symptoms that related to family violence. So looking at what kind of violence if it's a domestic violence call that you're on or that you're dealing with, that's going to be a different set of profile, different kinds of risk factors than if it's a barroom brawl, for instance. And we began to dissect, to look at, well, women veterans, what kind of, is it in response to being victimized? Is that what's going on? And in some cases, yes, but there were a number of veterans, women veterans, almost 20% that reported violence only, without any indication of it being in self-defense or because they were victimized. And the vast majority was family violence. So the risk factors in veterans, the role of PTSD, what type of violence you're assessing or encountering, and now, wait a second, everything's about raising risk. What can we do about it? Eric, I've got this veteran, he's at high risk. Now what do we do? And we decided to look at protective factors. What are some protective factors that are related to reduced risk of violence among veterans who have post-traumatic stress disorder? What can you do about it? And I have to say, you're going to hear, this is going to mirror a lot of what you heard earlier this morning, sleep problems. You could see that the veterans who did not have sleep problems were at half the risk of engaging in severe violence. Meeting basic needs, yes or no? Do they have enough money to cover food, shelter, clothing? Resilience, I think you heard a good story about that this morning. If they have resilience and they're able to want to take control of their lives and bounce back, that is associated with reduced risk of violence in veterans with PTSD. Social support, half the risk. Over 50% of veterans who are serving in combat report having some kind of back pain. That is the #1 medical problem. They are carrying heavy loads, 80 pounds plus, in unbelievable heat and multiple times a day, and they come back with chronic pain. That is related to increased risk of violence. I don't know what the situation is like in Canada, but in the United States, at any given time, 33% of the homeless population are veterans, whereas only 10% of the general population are veterans. There's a high number of homeless veterans in the United States, and you could see that that itself is associated with a higher risk of violence. Employment is very protective against violence. So beginning to look at these factors beyond the diagnosis that relate to lower risk of violence might be different approaches you could use to help figure out a plan to reduce risk. We wanted to look at, well, okay, sure, those are for all veterans, but what about veterans who experience the kind of exposure to combat that we hear about? Does it help them? Do these things help them? And you could see financial stability lowers their risk. Perceived self-determination was the strongest protective factor for violence, even when controlling for all others. So to the extent that the veteran in front of you feels control over their future, that is a very important question. That is a very strong predictor of whether they're going to act violently. Spiritual faith, resilience, social support. What happens when you put all these together? This is I'm going to explain this figure to you because there's a lot in it. On the left are the veterans who have no protective factors, and on the right are the veterans who have a place to live, are working, have financial stability, resilience, no physical problems, and social support. And what you can see is that the more protective factors, the lower the rate of violence in next year. And that is a 92% reduction in violence. And I should mention for these are people who have PTSD. It's all in this model. And the other thing, it's really hard to see, but important, is that there's only 12 people in that very high-risk group. And as you can see, going toward the right, the vast majority of the veterans have a lot of protective factors and are at low risk. So an important take-home is that we're talking about a small subset of veterans, many of whom have very few protective factors in their lives, that are at highest risk. The other take home is that you could do something about it. Rehabilitation, you heard about some things, getting a job, in addressing sleep. People may not be ready to go straight into cognitive behavioral therapy yet because they're exhausted. Anger, we have a grant right now where for veterans with PTSD, a lot of them drop out of treatment. Very few of them make it through their entire treatment regimen. And a lot of them want to learn how to relax. They have emotional dysregulation, they're very stressed out. We have a grant where we're putting a portable EEG, it's available, it's $99, it's called NeuroSky. And what it does is it reads alpha waves in your brain, has Bluetooth in it, it goes to your iPod Touch, and it gives the veteran feedback of when their alpha waves are in a relaxed state. And it trains them to learn how to physiologically relax their bodies. So we're beginning to look at, and a lot of them have pain, and it's meant also to reduce pain. So addressing the pain, addressing these, helping veterans get jobs, being aware of that, I think for those that have the luxury of being able to do case management or work with longer term, then that's something to keep in mind, is that those are all potential avenues for reducing risk. So protective factors, PTSD, what are the risk factors, and what kind of violence? The last take home to improve how you maybe deal with a veteran who might be complaining of anger problems is, well, what about risk tools? What can we do about that? And we, as part of the study, the whole goal of our study was to create a quick checklist to help. It was aiming to help clinicians, but can be used in law enforcement. It's being used by the U.S. Army Reserve Unit and the U.S. Army right now, and we're working on getting this in the VA. We created a 5-item screen. It's available for free, and it just involves these questions that you see on the screen. Do you have enough money to cover food, clothing, shelter? Did you personally witness someone being seriously wounded or killed? This one I like. We threw in all these alcohol problems and alcohol items, and the one that was strongest was, has someone told you you've got an alcohol problem, not do you have an alcohol problem? That wasn't so predictive. History of violence toward others or arrested for a crime, that was the strongest predictor of whether or not a veteran was going to be violent. And then in the past week, how many times have you been irritable or had outbursts of violence? Not PTSD as a diagnosis, but the specific symptom was most predictive. And what you could see here is that, similar to the other graph you saw, the vast majority of the veterans were not in that high-risk group. But the ones that did have all of those risk factors, over half of them were severely violent in the next year, compared to the ones without the risk factors. Now, what can that do? What can that checklist do? What can't it do? It's very important. At the very least, it can help, it says clinicians, but it could help people encountering veterans at least think about 5 factors that have been shown in the science to be related to violence. You should definitely be looking at others, but if you're going to ask anything, these show a strong relationship. It might identify which veterans that you're seeing are at highest risk and therefore need a more comprehensive risk assessment using the kind of more comprehensive tools like the HCR20 to really do a more thorough job of seeing who's at risk and who isn't. The other thing is that some of these are what are called dynamic risk factors. You could change them. So going through this list might give some avenues for intervention. What if the reason why they don't have enough money to cover those is that they're really bad at money management? I've been running both money management groups and anger management groups at Veterans Affairs for the last 7 years. And I could tell you that many of the veterans, and this is one of the reasons why there's a high homelessness rate, they're getting out of the military at the age of 32 and paying rent for the first time. They've never paid a bill in their lives. They've had their clothes picked out for them, their food. They don't know how to do this. And so one of the interesting things to think about with this protective factors, and when you're seeing a veteran, is when they were in the military, they may have been seeing bad combat, but they had a roof over their head. They had food. They had a job, self-determination. They had missions. They had their basic needs met. And when they leave the military and go to civilian life, we think, oh, well, they can handle it. But the carpet is swept out from under them. And suddenly, all these protective factors that they had, they have to figure out themselves. So that's one of the other parts of veterans that we've seen is that, yeah, the PTSD is relevant, but it's almost just the tip of the iceberg. What about this transition? And that would be a question to ask. How long has it been since you're separated from the military? Have you been able to get these protective factors in place? And it's called the VIO-scan. What the VIO-scan does not do, it does not replace a comprehensive risk assessment. It's just a checklist of items that have been shown in the science to relate to violence in this population. It does not have perfect accuracy. It doesn't have labels of high, medium, or low risk. The higher scores don't mean that someone's going to be violent, and lower scores don't mean someone's not going to be violent. It's just meant as a springboard for other avenues of intervention and assistance. So I'm going to do a recap. A subset of veterans, Canadian forces, probably this relates to them too. There's no data I'm aware of, but American veterans, a small subset has problems with severe violence. A higher number report less severe physical aggression. So that's number one. If you can't tell, the link between PTSD and violence is very complicated. The diagnosis alone isn't as important as when PTSD is combined with alcohol abuse. So the veterans who had PTSD but who weren't abusing alcohol were 72% less likely to be severely violent than the veterans with PTSD who were abusing alcohol. That combination seems very, increases risk dramatically. And not just the diagnosis, what about those symptoms? Anger symptoms, hypervigilance, the paranoia, the lack of sleep, those relate to violence more consistently. And just as important is to realize that yes, PTSD is playing a role, but there are other things, other factors, just like the rest of the population that are at play, and in many cases even stronger, particularly past criminal behavior. Because the number of veterans were arrested had criminal behavior before they were ever in the military, or violent behavior before they were ever in the military. And looking at economic and social attainment, the way that that interacts with PTSD symptoms and can exacerbate them, the stress that causes cannot be overlooked. And again, younger age, just like in the general population, the younger age, the more at risk. And lastly, those protective factors. So you have someone who's at risk, has those risk factors, what can we do to reduce that risk? Thinking about their physical functioning, their psychological functioning, their economic functioning. In the anger management group that I run, it's called client-centered anger and life management, or CALM. I don't know whether it's the same here in the Department of Defense and the VA love acronyms. I mean, I was actually, I got to meet the former director of the VA, and in the meeting with him, he didn't even know one of the acronyms, so I felt good, Eric Shinseki. And, but one of the things, so in this group, and my daughter calls it cool and laid back mood. But the veterans like it, but that won't work with the VA. So in that group, what we do is we target these protective factors from the onset. What are some of the contributors in your environment? What are some of the things you can do to reduce your risk while you're going through PTSD treatment? And so what I think is, when I do an interview and doing a risk assessment, rather than start off and say, hey, tell me about your violent behavior, or tell me about when you shot a weapon in Iraq, I start off and say, hey, tell me about what your plans are for the future. How self-determined do you feel? How much in control of your life do you feel? What are your interests in jobs? Tell me about your friends, your family. I start off with the protective factors. It's less stigmatizing, and I know that, and it's also a little disarming because a lot of veterans think like they're going to be asked all these questions that are uncomfortable to start off with. I start off by going over those protective factors. They're statistically important, and also do you have pain? Veterans are more likely to acknowledge that they have pain than they have PTSD, and so that's a way to get them to deal with both. Sleep problems. Are you having sleep problems? Those are things that veterans want to talk about. Then assessing violence in a structured way, whether you use these tools or at least go through the factors that I talked about. At a minimum, it would be good to be asking about PTSD and its relationship to alcohol abuse and to anger and other of those symptoms. But to also think about those non-PTSD factors. Do they have a history of violence? Are they younger age? Are they financially unstable? So what are some of the civilian non-PTSD risk factors that you want to throw into the mix? And finally, considering the use of the screen, the VioScan, and because so many of the factors overlap civilian risk assessment tools that have been validated on civilians, with just the caveat that right now there is limited validation. We are working on that, and I'm working on it right now. And but really, we do think that using the screening tool, if you have the luxury to do a comprehensive risk assessment, certainly those are all relevant to use in this population. So those would be those are the 4 take-home messages that I know I've repeated a bunch, but hopefully you'll take home that most veterans are fine. There is a subset that does struggle. It's not just PTSD, that's the tip of the iceberg, and to get beyond the knee-jerk reaction, but to see there's other factors at play, like alcohol abuse and anger and paranoia and hypervigilance, to consider all those other non-PTSD factors that are at play, just like for civilians, and to really think about how can we enhance this whole situation by facilitating protective factors so that we can best help and serve those who've served us in Canada and the United States. Thank you.